Hello there, and happy Thursday. I am joining you live to answer a great question that got sent to me. If we haven't met, my name is Julie Hirschberg. I'm a neurologic physical therapist. I'm the owner, founder of Re+active Therapy and Wellness here in the Los Angeles area. And I do a lot of teaching about functional neurologic disorders. And I'm getting hey from Ellie. Hi, I'm so glad you're here. So I do a lot of teaching on functional neurologic disorders. I've done a lot of webinars and classes for the APTA or the neuro section of our Physical Therapy Association. And somebody who had took one of those sent me an email, and it literally had SOS in the subject. And I've never gotten an SOS email. And so, of course, it grabbed my attention. So I guess if you want to get my attention, send me an SOS email. I might become immune to it. But I want to share with you a little bit of this email. And I told this therapist, so this was from a physical therapist, I said, hey, I'm going to hop on a live video. I'm going to talk about this because this is a very common question that I get. So this is from Sarah. Thank you so much, Sarah. I feel honored to be in a profession of clinicians that really, really care about their patients and ask great questions. So for privacy, I'm not going to give all the information about the patient, but essentially the patient has had a functional neurologic disorder, functional gait disorder for almost 3 years now. And it's presenting like a left-sided hemiparesis. And by the way, I'm just going to let my dog out here because he's going to be barking. I usually do this before I start these, and I did not, so I apologize for that. So this person has a functional gait disorder presenting as a hemiparesis. This is a common presentation. By the way, this has been a presentation since like the 1400s. The history of this presentation is very common as a functional disconnect. And this therapist, Sarah, you're amazing. Already this person was using a wheelchair, now is no longer using a wheelchair, is walking, and has just now not even having a brace or an assisted device in the clinic. So truly amazing progress already. So I just want to give a big shout out to Sarah for the great work that she's already doing. But then Sarah says, now I feel stuck. She kind of wants to know, what can I do next? Particularly, she wants more automatic skills that initiate that automatic motor response. So unlocking that motor response. Particularly for carryover. So that's why I wanted to share this, because I think the carryover can sometimes be tricky. And appreciate any feedback that you have. So again, thank you, Sarah, for this great question. And I'm so excited to share all of the ideas. So what I really want to start with, and I downloaded images and everything, is in understanding the patient. So obviously I didn't get a ton of information about this patient. So Sarah and all you other therapists, this is where I would start. There's not a magic bullet for functional gait disorders, by the way. And there's not a one-size-fits-all thing, but there is a magic framework. And that framework is exactly what Sarah took a course, and we use our framework all the time. It starts with listening to the person. And Mike Studer used a great term the other day. Have you taken the vital sign of that person's personality? Do you know stuff about them that is not in their medical record? And that is where I'm most curious about this person who has a functional gait disorder, because if I'm going to help unlock automatic movement, I want to know a lot about this person. I want to know what drives them. I want to know what makes them smile and laugh and what they really, really want to accomplish in life, because those things are going to drive automatic movement. So number one is that listening piece. And I want to know very deeply. And Sarah, I think you're a phenomenal therapist, so you probably already have these things. So let me just make up a few. Let's say this person really loves to get outside and go hiking. It's actually a beautiful day out, so that's what I was thinking about. I love hiking, and they love some really great music while they're doing this. They love going to concerts and live music. They love strawberries. I know this all seems really random and it would not be in the medical record, but these are the things that you're going to use. Every little detail, the music, the strawberries, the books they love to read, the movies they love to watch, the sports teams, if that's their thing. Every little piece is going to be a part of unlocking their automatic movement. So first step, listen, get the vital signs of personality so that you can incorporate this into treatment. And as Ellie said, Ellie, by the way, Dr. Madrid is a physician who we have the great privilege of working with. And she says, I would put those things in the medical record. So would I, Ellie. So would I. Because they're important about this person and their life. And if we're working to help them get back to their life, these things are really important. So I would as well, Ellie, thank you so much for saying that. So you're going to listen to those things. They're going to give you a ton of clues of how to set up some of your motor control training. Second, I want to understand how that person understands what is happening in their leg. So if somebody is experiencing hemiplegia, and it's very typical, and this is how Sarah described it, an external rotation and kind of dragging the leg along, very common presentation. How do they understand that? Do they feel a disconnect from their leg? Do they feel it's then maybe kind of a sensory issue, like I can't feel the leg very well? Do they not trust the leg? Do they feel, did they have a physical injury to the leg and it has that kind of disconnected feeling because of the physical injury? Do they think there was something going on in the foot or the ankle or the knee or the hip? Any of those possibilities. I often think, I grabbed it here, I often think of Oliver Sacks because he had a physical injury to his leg and actually had nerve damage and other things. And during the course of that, he developed very much like this case, a functional gait disorder, almost like a hemiplegia. That leg felt like a piece of chalk is how he described it. I want to know, how does this person understand their leg and what is happening? Because I honestly, I need to know their understanding so that we can build an understanding together of what is occurring in this functional gait disorder. So that's number two. Number one, the listening. Number two is gaining that understanding and validating that understanding. So for example, Oliver Sacks had a leg injury. He couldn't feel his leg. I better check that sensation, right? I better confirm, you know what? You're right. The map of your leg is not quite right. And let's figure this out together. Let's figure out why, right? So that's why I say that understanding and validation. There's a question in here too. Curious, what are the neurophysiological processes in the brain that help unlock the movement potential when we build rapport? Ooh, I love that question. So Lily asked this question: what are the neurophysiological processes in the brain that help unlock automatic movement potential when we build rapport? So I think there's two pieces, because I wasn't even talking about the neurophysiologic processes, but since you said so, let's talk about that just briefly. I think of several things, but probably the biggest one is safety. So that rapport is not just to build a buddy. That is to literally understand and be with. So when you're in a therapeutic relationship, you're being with that person, right? When you are with that person, you've got nervous system sharing, right? So you're co-regulating with that person from a sensory perspective, from an autonomic perspective. And that's not woo-woo, that's like scientific, that's neurophysiologic processes. What I understand and believe about the person is just as important as what they understand and believe, right? And we need to come together and meet in the middle of that. I'll just give an example of this, and this would be very important in this case that Sarah brings up. If you believe and you're fearful of the person, and their unusual presentation that you're not very familiar with, that will tend to decrease the trust, decrease the safety in that therapeutic relationship. And you'll tend to also underdose. There was this really great study on physical therapists and kinesiophobia, and they actually underdosed the weight training for people based on their own fears and kinesiophobia. So that's something that is really important, is you want to check yourself, right? So check your own beliefs. So thank you for the great question, Lily, for that. And what I was really talking about is getting to know that person so that you can truly personalize the therapy that you're doing, because that is huge when you're trying to unlock automatic movement. And but Lily brings up a great point, is that listening is actually also starting to change their nervous system as well. So really, really great point. Okay, so we talked about listening. We talked about validating and getting a good understanding of their understanding of what is happening in the limb. And I believe Sarah, who asked this question, already is doing these things, by the way, because she's already helped this person so far. I'm so impressed by that. The third is breaking it down. So this is our pie chart formula. And this week we have Pie Day. We celebrated with pie and we shared our pie. So I'm going to even share a picture of our pie. This is the reactive way, I will say. This is what we do with every person that we meet who may be a part of our program. But when somebody asks me a question, and my whole team knows this, and my Brain Bites team knows this, when you ask me a question for like a particular treatment or things, I'm going back, what's their pie chart look like, right? So Sarah, I'm coming back to you. I want to know what the pie chart looks like, because even when we see a movement problem, we want to understand what's the underlying issue. For sure, we know there's a motor control issue, but what about the other systems? I think they get overlooked when it's a motor problem. And so sensory, I already talked about Oliver Sacks in the leg to stand on. I think Oliver Sacks, I bring this back anytime I see kind of a functional motor issue because that's exactly what he had. And one limb, what is the sensory map of their leg? Do they feel disconnected from their leg? Do they get good kinesthesia? What's their 2-point discrimination look like? But basically, what does the leg look like in the brain? We can take a look at that. I will often find that it might be a little smudged. It might look like a piece of chalk, like Oliver Sacks described. And we can test that out, and then we can treat that. So if you are struggling to see carryover in a motor control issue, you might want to see, is that person getting accurate sensory feedback? Because sometimes they're not, and then it's really hard to make change. So the sensory system, a really big one. So I'm giving you the subjective part of the pie. Let me give you the objective part of the pie, because one is from the story that they're sharing with you, and the other is from the testing that you're going to do. And so here's the objective pie. And Sarah, I know you got the objective pie because you did a course on this. So I started at sensory. Let's go kind of around the pie. I think it's really tiny on here. But the second is psychosocial. So again, if a person had an injury, I'm going to go back to Oliver Sacks, with the leg, is there a disconnect? Is there a lack of trust or safety in the leg? Those are all things that we'd want to explore and build. Lifestyle. I think lifestyle in this case, whenever anybody says that there might not be carryover, I want to understand lifestyle because how is this person able to implement these at home? Are they doing anything that they want to do right now? Is there any joy in their life? Not that we got to be like joyful all the time, but what I really mean is that person engaged in something they really want to be engaged in? Art, dance, music, hobbies, any of those things. And if not, how can we, and we do this with our OTs, so shout out to all my amazing OTs out there. We do this with our OTs all the time. How can we incorporate those? I don't even care if you don't have to use the leg in the activity. Can you engage in a joyful activity? Now, we're going to start putting the leg into that, right? So of course we're going to incorporate walking, and other activities with that, but we don't need to start there. We do need to start with getting back to a purposeful, meaningful life. And so that is a big component of carryover that I firmly, firmly believe in. Somebody's asking here too, how do we bridge the disconnect between the brain and the legs? We are doing it right now. So we talked about sensory, right? So when there is this disconnect in a functional gait disorder of some way, we actually want to know what is the disconnect, right? So I'm opening the framework here to explore where that disconnect is. Sensory is an often overlooked piece. So I want to know what's the sensory map of that leg in the brain. Psychosocial pieces, disconnect can be a big piece. So we want to create a psychosocial bridge. This might be with a psychologist. I think working together with PT and OT is super important. This might also be how you're providing safety and reconnection within your physical therapy session. And then we talked about lifestyle. Autonomic, one of my favorites. We're doing Naoya, our OT and I are doing an autonomic web workshop for people with neurologic disorders, by the way, next week. So we can talk more about that. But for Sarah and for her question, I would actually want to know, are there autonomic changes going on in the leg? Skin color changes, temperature changes, pain happening there. Because again, really hard to get carryover if those autonomic pieces are not regulated. Is there a change in heart rate or heart rate variability with walking? We might need to regulate the nervous system a little bit more in order to improve those automatic movements. So again, when you ask, how do we bridge the disconnect between the brain and legs? We need to figure out where that went awry. Autonomic might be a piece of it. What's their exercise tolerance in general? What's their tolerance for being upright? Nobody can walk normally if they can't tolerate being upright. So let's look at those pieces. And then at the top here, physical limitations. Let's not ignore that there may be a physical limitation. I think physical therapists are really good at screening this, range of motion issues, strength issues, those kinds of things. I think nerve tension sometimes gets overlooked. So that's one that I will always point to see, hey, is that person externally rotating and dragging their leg because of nerve tension? Like that is a real possibility. So let's take a look at that. We can easily rule that out. So I went around the pie, but I didn't start with motor control because I think that's the most obvious when it's a functional gait disorder. So I hit on all the other ones. Let's talk about motor control. How can we unlock automatic movement? And I think it has to be in a way that is super duper salient to this patient. So I know we talked about hiking and being outdoors. And so this is going to be really, really particular to this person. And when you said, Sarah, that maybe there's it's not carrying over. So maybe you're seeing some things happen in therapy, but then it's hard to do at home. I'm going to spend the majority of my session finding many, many ways to unlock the movement and recreating those for home. And I'm a big fan of making it so playful and fun, you don't even know what's happening. So in the motor control realm of things, we always think of the optimal theory. I know you're already doing this, Sarah, but we think of autonomy, external focus, and enhanced expectancy. I think many people automatically, the external focus, so they're stepping over objects, they're kicking objects, they're hitting balls and balloons, especially for walking. And maybe then you're actually seeing those automatic movements, but then the person goes to walk at home and it's right back where they started. You may need more repetition of those automatic movements. You may need other ways. You may need ways to take those home with you. One of my the favorite ways I did this was somebody with runner's dystonia. We actually strapped a teddy bear to her leg, and this was the thing. She could run with the teddy bear strapped to her leg. So I want you to explore that. What is this person's teddy bear? What is it that they may need to take? And you know what? It might be an assistive device. It might be a song that they're listening to. It might be that you actually are helping them regulate their nervous system with walking. So another example of this would be that I might use autonomic and I might use some heart rate variability training with walking. And that is what actually allows some of the automatic movement. So you've got to be really creative here and tap into, again, what is important to this person. So I'm going to just switch here, and I see some great questions coming in to the treatment. I know we were talking about objective, but I'm a firm believer that you've got to assess to know where you're going to go with treatment. Let me get to these questions here. What about biofeedback? Yes, some research talks about, excuse me, distraction versus attention in F&D. So I have used biofeedback in many different ways in F&D. One of the biofeedback mechanisms I love the most is in the autonomic world, and that's heart rate variability training and biofeedback. And I use it during walking. I found it really effective for the person who has a lot of nervous system dysregulation that's interfering with the walking. So heart rate variability feedback, we use the Leaf. It's an EKG monitor. It provides feedback about your heart rate variability in the moment, and it guides you through practices to improve your heart rate variability. And sometimes with that, people's gait changes if autonomic is part of the issue, right? So not everybody, but that's why you need to test it out first. So up in the motor control piece, we talked about optimal. So we talked about external focus. Sarah, I think you're already doing this. I wonder if there are some other pieces that you can have that person take home with me. Think of the teddy bear example. Number two, autonomy. Where can you provide more autonomy for this person in their walking recovery? And I think, again, how is it set up at home? So if you've put together a program with them, can they have choice in when they do it, what they do as part of that program? Can they self-design that home program with you? So those would be some ways that you can incorporate autonomy. The third, and I think this could be really important for you for functional gait disorder, is enhanced expectancies. So there's several ways to do this. I'll just give a really simple one. Is I think it can be really helpful for the person to know what's possible and for them to visualize and see that. So using video examples of other people who have gone from that exact same gait disorder, which I've seen several people myself. We actually have a part of our YouTube has our YouTube channel has these stories in pre and post. So videos like that for a person to see the changes. But I also tap into graded motor imagery. So I could go on and on, by the way. So Sarah, we could have a 2-hour conversation about this. But when it comes to motor control, and I think of this with enhanced expectancies too, I may want to introduce graded motor imagery. And I've talked about this before, but very briefly, how I might use it in the case of somebody with hemiplegia is we can go through the whole process. I might start with the Recognize app. How are they recognizing foot and knee and hip and maybe even back? And do they have that sensory perception and awareness of their limb? Then I might go to imagined movements, and I might video walking, myself walking, maybe on the treadmill, and they're visualizing and watching that symmetrical walking. That would be one example. Then I would go to maybe mirror therapy. And by the way, I switch around these orders based on the person all of the time. But in this case, I would have them looking at their other limb, the less involved limb, in the mirror. So there I use a standing mirror, and I would look at them, or have them look at their limb moving in that mirror. I might do it on a treadmill. I might do toe tapping. I would really do all kinds, like kicking a ball, whatever it is. Then I would add in that they're actually moving the limb behind the mirror at the same time. I found this can be very, very effective for functional gait disorder. And then I want to do a graded exposure. So again, I think when the question comes up about carryover, I wonder, like, where are they in the exposure of doing this? I can't really expect that somebody is going to do something, stepping over objects in the clinic, and then boom, they're going to do that everywhere else in the world. I just haven't really seen that just happen miraculously, but I have seen it if we gradually expose to the most challenging situations. So this is where I ask the person to help me, like, what's the easiest situation to walk? What's the hardest situation to walk? And how can we actually just build up to those situations? If that person needs some extra sensory input, like a weight or like the teddy bear, like I said, or if they need an external focus initially, great, let's use that. And then we'll gradually decrease using that. So I would go through that graded motor imagery, graded exposure process with their walking as well. So there's a lot in the motor control piece of the pie for you. And I'm just going down here, optimal all of the way. And then I'm getting another question here. How about your non-walking patients? And hey, I'm here to tell you, Sarah took the non-walking patient in a wheelchair. She took our course and she got them walking. They're not even using an assistive device anymore in the clinic. So in those cases though, and I'm not sure exactly what Sarah did, but many high fives and kudos to Sarah. I'm here to tell you the therapy world has amazing therapists. They're just phenomenal. So Sarah, I think you're great. But in the case of somebody in the wheelchair, and maybe it's both legs involved, then we go back to the pie, right? So here's the thing. Not a magic bullet, a one size fits all for everybody, but there is a magic framework. If you listen to them, understand their story really deeply, understand them as a person deeply, understand their understanding of what is happening, then add in breaking down what are the underlying issues. So somebody in a wheelchair may have a lot of autonomic involvement. They may not tolerate upright. So we need to work there first. It might be a sensory issue and we need to work there first. It might be lifestyle, psychosocial. There may be physical impairments keeping them in a wheelchair and we need to work there first. So that would be the piece, is that we would really need to start and meet that person right where they're at. Here's another person that says, my PT is great at finding things that work for me. Yes, 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 I'm so glad you said that. I think PTs, OTs, psychologists are really great at finding things that work for people. And here I think is the holy grail of carryover. It's not just that I can find things that work for you, but that together we find things that work for you, and that you have the power then to find things that work for you. I'm just going to open the door. We're going to discover it together, and then you're going to have the tools to keep going so that you have that really terrible day where I know around here the weather's gone up and down and people are like, oh my gosh, like this weather changes like make my symptoms go crazy. Well, you would then build yourself up the tools so that you're discovering those things yourself. That's the holy grail of therapy to me, is that the person has all the tools. And when I hear back from people that are like, hey, I had this happen and I figured it out, I'm in tears. Like that is the ultimate. And so that would be one piece, Sarah, is how many tools does that person have? How empowered are they to really be able to implement this on their own, which is lifestyle is so critical. So thank you, Sam Pie. You've got pie in the name. I love that because I love pie, and here's my pie chart. Knowing the clinical interest is so important, but lifestyle is so critical. I do not think this can be done without the lifestyle component. So I'm so glad that you said that. That's why it is a piece of the pie here. So really fabulous. This has been a really fun discussion. Again, I want to thank Sarah so much for sending the SOS email, because this is a very common question and we had a lot of other people interested in this topic too. So I thank you so much. I'm so lucky to be a part of a community of therapists that care so deeply about this. So thank you for being here, for caring alongside of me with about functional neurologic disorders and helping people get back to their lives. I appreciate it so much. If you are a person, by the way, with a functional neurologic disorder, we're doing a free workshop next week on the autonomic nervous system. Hey, if you're a therapist, you could come too, but really it's geared towards patients. So we're going to talk about anatomy, we'll talk about assessment and treatment, and empower you to advocate for yourself. So it's going to be really great. It's next Tuesday evening, and you can sign up at a link in our bio or at reactivept.com/workshops. So yes, it's next Tuesday at 5 p.m. Pacific time. Will be about an hour and a half, and we'll go through that. We'll answer questions. Of course, we can't provide individual medical advice, but I will post about the workshop. Yes, thank you for the question. I'll post about the workshop, and you can join us live. And if you can't make it live, we always record it, send it out. We'll send our handouts out, resources, and so on. And again, it's at reactivept.com/workshops to sign up. So you can join us next week. Here, I'll stop. No, I'll keep sharing the pie because I love our pie chart. If you are a healthcare provider and just love this deep dive in FND like I do, I would love for you to be in our community. We're going to open our doors next month, and that's our Brain Bites community. Join our waitlist so that you can hear about it ahead of time, and that's at reactiveeducation.com. So thank you again so much for being here with me tonight, and I'm actually going to go live tomorrow. There's a couple of really great pieces of literature that came out in functional neurologic disorders. So I will be sharing that tomorrow. So I'll see you there. And thank you so much. Have a great night.